Okay, so we'll get started. Pop, you'll be moderating, so I'll let you introduce the panel.
Okay, great. Good morning, everybody, and welcome to our last panel this morning, which has been a very rich discussion so far. And this panel will focus on the health workforce. If there is one subject matter that really has now been front and center, unfortunately partly helped, I think, by the Ebola crisis and Time Magazine's recognitions of the health workers, this is a very important subject. And in the context of public-private partnership, I hope our discussions today will look into the future. And we've been talking a lot about paradigm shift. I think this is an area where we urgently need a paradigm shift because we have in our hands, obviously, a major issue. I think it is recognized throughout by everybody that if we are to make progress in the development agenda that we have before us, and if we have to make progress in rapid economic growth, we have to find a way to solve the issue of the health workforce crisis. But I also believe that time is of the essence, in that we have spent so much time talking about the crisis and focusing on the crisis. And there are a few things, in my opinion, that we need to do to pass that stage. How can we maybe talk about it in terms of the opportunities, and what are some of the new thinking, some of the new savoir-faire that now is in our hands. So let me just take a couple of minutes to sort of set the context here. We are still talking about a world that is lacking 7.5 million of health workers if we focus just on professional health workers, whether it's doctors, nurses, midwives, and some other cadres. We are not counting, of course, community health workers and it's like that in that picture. So our world is still challenged. In some parts of our world, there's a high need for nurses. In some parts of the world, there is even greater needs for nurses and other cadres. So this remains a global problem. We have to factor in people's movement. We have to factor in migration. We have to factor in human rights because people are trying to have better life. So there's been a lot of talks about how we retain the few workers that we have. So we are still in a world that is challenged when it comes to the health workforce. We also know a lot. Thanks to some global champions, I'm happy we have Ariel with us because certainly both Ariel and others have been working on this. And I think to have the institutional memory and somebody who could really help us trace the progress is good. But so we know a lot. We know a lot, especially at the global level, because 2006 was when the World Health decided to dedicate the report on the issue of the crisis. And we've made some progress. We've gotten, the third forum was organized last year in Recife. So our world has gotten a lot smarter on the issue. But there remains a big gap, the famous no-do gap. We know a lot, but we are still not doing enough. We also have some new topics on the agenda. Global health security is certainly one of them. This discussion is being had in the context of public-private partnership. So, in my opinion, the challenges that we have are, we still have the numbers, but I think the biggest challenge is that we have a lot of inefficiencies, because in my humble opinion, if we do a good job of maximizing the health workforce that we have today, we can double, triple, quadruple the progress. If we continue to just remain in the crisis, because we know, to be realistic, it's going to take a long time to produce the right quantity of health workers. So we have to work at two levels. We have to be thinking long term. How do we continue to replenish the pipeline? And then on a short term, how do we deal with today's crisis and today's needs? So with that introduction, I would like to invite our panel. I think we have a very rich panel here today. We have David from the GE, who has the private sector perspective. We have Ariel, as I just said, Ariel Pablo Mendez, Deputy Administrator of USAID, who's been one of the global champions who really has a great mastery of the health workforce agenda, who could give good perspective. And we have Kate Tulenko, who is Vice President at InterHealth and who also manages the Capacity Plus, which is USAID's flagship project on health workforce and generating health workforce solution. So I'd like to open the discussion and ask our panelists to start, and if I may ask you, in your remarks, to address a couple of issues. One of them has to do with the discourse. How can they help us have some new vocabulary, some new language, so that we don't continue to operate and to talk in terms of a crisis? I mean, it is there, but I think there's some language our field might be missing around economics, around the value, because really you're talking about the intervention that is key into any health investment. So I'd like you to address that. And then the second one is just in terms of paradigm. It's thinking that we have now new actors in the private sector that have entered this space. What do you see as opportunities with these new players on our ground? And maybe starting with David?
Sure.
Thank you.
Is this on? Yeah, perfect. Thanks very much. I appreciate it, Pop, for the opportunity to talk, and thank you, everyone, for sticking around through the morning and holding on for the last panel. Hopefully this will be engaging and interesting for you. I have a couple of thoughts about the healthcare workforce and where we come from. First of all, as a healthcare provider myself, I'm an emergency physician. I think that the healthcare workforce is really the engine that drives healthcare. And we've talked a lot about technology this morning. We've talked about funding. We've talked about systems. But really, the healthcare workforce are the people who have their hands on the patient. They're the ones who, day to day, whether it's Ebola or a non-crisis event, the ones who are actually interfacing with the patient. They're the ones who are trusted in the community. If you think about why people come to the hospital, it's not because there's a device there that can take care of them, but because there's a healthcare worker, a physician, a nurse, a community health worker, others who can provide care for them. And healthcare workers also provide a huge economic opportunity for us. I think the more we train healthcare workers, the more we create jobs. I think we create jobs in the community. And I think we create opportunity for those who are probably the largest part of the healthcare workforce, which is women and girls. And if we think about rural communities where we're trying to train new people to deliver health care, you can see young girls in those communities actually seeing opportunities for themselves to become healthcare workers and to become involved in the healthcare system. I just want to bring up a couple of issues that hopefully will be provocative for thought around healthcare workers and how we talk about it. The first one is we talk a lot about task shifting and task sharing. I think it's really important as we define our training that we really move that paradigm forward. We'll never meet the goals of training healthcare workers if we stick with the current paradigm. We have to push that training out, we have to simplify the training, and we have to enable people who we traditionally might not think of as healthcare workers as potential healthcare workers. That's the only way we're going to get to those numbers that we need to get to. The second thing is I think we need to broaden the definition of healthcare workers. Pop and I were talking earlier, and I think we traditionally think of healthcare workers as doctors, nurses, community health workers, people who actually put their hands on the patient, as I was talking about, and actually deliver care directly. But I think that's probably limiting. I think we need to think about other programs and other providers like biomedical technicians. Without biomedical technicians maintaining and fixing medical equipment, the question of service was brought up earlier today. It's done by biomedical technicians. If they're not there and thought of as healthcare workers, the equipment's not going to work. It's not going to be ready to enable who we traditionally think of as a healthcare worker to do their job. I actually think we have to think of hospital administrators as healthcare workers. Without good management and without good leadership in the hospitals and the community health centers, we're never going to be able to accomplish the things that we want to try to accomplish. So I think we have to broaden the definition of who we think of as healthcare leaders, healthcare workers. And the last thing, which I hope we'll all think about, is that healthcare workers are only part of the issue. Paul Farmer talks about staff, stuff, space, and systems. And the healthcare workers are the staff. But if they don't have stuff, if they don't have equipment, if they don't have supplies, if they don't have clean facilities within which to work, if they don't have hospital space, if they don't have an OR with lights that work, then they're not going to be able to deliver care. And the last part is a system, and I mentioned a minute ago management and leadership. It's important that you have management and leadership to pull that whole system together. I'll just give you one brief example, and then I'll close. We have a program, we do biomedical technician training as part of our work at the GE Foundation. And we trained biomedical technicians, over 200 biomedical technicians now in 5 different countries with sustainable programs now, so they can continue to deliver or develop new biomedical technicians in those countries in which we're working. And we started thinking about how we're building capacity, and we're starting to see that there were needs in the operating room and to deliver safe surgery. So we began to train nurse anesthetists, and we're doing a program in Western Kenya where we're training nurses to deliver anesthesia independently at the last mile, in the remotest parts of Western Kenya in this particular case. The problem is, if you train nurses to deliver anesthesia and ask them to go into an OR to deliver anesthesia where there's no lights, there's no clean water, there's no surgeon who can deliver the surgery appropriately, there's no equipment, there's no monitor, there's no anesthesia machine, you've trained a nurse to become an anesthetist, and you've spent money unwisely because they don't have the rest of the things they need. So as we're thinking about training the workforce, let's think about the other things that we need to put that system under the workforce to give them a foundation to let them be successful as they are trained and enter the workforce. So I'll stop there.
Thank you. Thank you, David. And Ariel, obviously, USAID has a major role in supporting the health workforce issue, but you also bring in expertise from WHO in the past, from the Rockefeller Foundation when you were there. So there's nobody better placed than you to share with us your thoughts on first the evolution of this field and where do you see this field coming in the next 10 years?
Becoming the old man on the panel. Well, obviously, we all know that there's no system without the health workers, and that indeed health workers are not only the frontline health workers, which are so important, but also everybody else who contributes to health directly and indirectly. And we know maybe half of the systems in evolved systems are not in direct patient care. Many of us are still involved in health, and yet we're not in the front line every day. And so they're paramount, and the awareness as a global movement of the importance of HR really got going a long time ago with formal professional education, the creation of modern professions over 100 years ago, and then models that evolve and so on. But it is, I think, quite important in the early, about 10, 12 years ago when the Joint Learning Initiative gathered everybody. Many of you are here. I see Lola and many others who were part of that efforts to look at why this is important and what is it we can do. And it was a good exercise because it actually brought data to the table, and that was really very important. And in a way, it has given impetus to the issues that became. There was ACE, there was tax shifting, there was the code of practice on recruitment because of brain drain. There were many of those issues at the time that the data illuminated and guided. We are entering a new era now, and the data has lagged, and thus the imagination of the framing of the new era has not quite yet crystallized. But there's been a lot of progress, I think, in so many dimensions. There is now an impetus for universal health coverage, and of course, universal coverage will mean providing access to the services and the service providers, and so that would be an important framing in post-2015 for health workforce. As we discuss this Sustainable Development Goals post-2015, we speak of what we call the means of implementations, and that is measurement, which we are addressing with the roadmap and the measurement summit. There is, of course, financing, and we discussed issues of domestic resource mobilization, the global financing facility as attuned to this new future. And likewise, we're working with many of you and with the World Health Organization to have a new global strategy for human resources for health. That has been doing a lot of creative thinking and harnessing those ideas from around the world to bring to bear in this space. And I think data is going to be very, very important, and as well as data in the context of economics. And you were asking for what would be a new paradigm, and I think in addition to the service provision demands that will grow with universal health coverage and economic growth, is the opportunities to understand the role that health plays in economics, right? And Tim Evans mentioned before that with the growth in economics, there is a proportional increase, at least in the health expenditure, but actually, most typically, there is a faster growth in health expenditure than GDP. So unlike agriculture that shrinks as a proportion of the economy when economies grow, health sector grows as a proportion of the economy. And we have been looking at this data, but when you actually look at the labor part or mirror of that, it's even more dramatic. That is, health is occupying a greater chunk of the overall labor force in societies. And so we are now beginning to look at health, in addition to being an investment in its own right, not only for social but also for economic reasons, as the Lancet Commission highlighted 2 years ago on investment in health. One of the best returns, Larry Summers says, you can have is investing in health. But there is this dimension of the workforce that is about jobs. And right now, as we go into post-Ebola recovery of resilient health systems in Western Africa, and I understand you have Kent Brantley this morning, one of our heroes in the response. As we do that, the plan that Minister of Liberia, Minister of Health Liberia, which I and others have put together, is really going to be one of the largest job creation waves in Western Africa. I think when you begin to look at the health workforce in that sense, then it speaks to ministers of finance in a different way that just is increasing the budget of the Minister of Health. And in addition, we know the private sector will be very important, both in the training, as we heard, but universities, private universities are springing everywhere. How do we keep it all together? And I would say that we will need increasing amount of information and data. And one of the things we're doing with our partners, because we have done a great job, I think, Kate and Papa, on something called IRIS. 60% of the government's budgets in health is for staff. In managing that, this tool has been very effective. But looking at the whole and the overall labor projections and macro projections will be very important. And the National Health Workforce Accounts, a new idea, equivalent to the National Health Accounts for financing, that will allow us to have a process, not just a form sent to WHO with some data, but a process of ownership, of understanding of projections and planning that I think will help us in this field and will yield many opportunities. So I look forward to working with many of you in the new global strategy for human resources as well in post-2015, National Health Workforce Accounts, continued support for IRIS, and anything that will help ensure that we will have will fill the gap in the quality of the services we all need for universal health coverage. Thank you.
Thank you. Thank you, Ariel. Dr. Kate Tulenko, of course, has been heading the Capacity Plus project, and want to share your perspective on what are some of the key issues and that you think we need to be shared here.
Thank you, Pop. IntraHealth sees health workers as a cornerstone of the health system. It's that part of the health system that holds the rest of it up. And we think this is especially important in the SDG area, because SDGs have 17 goals, only one of which is health, whereas in the MDGs, the majority of the goals apply directly or substantially to health. And so we really need to, as a community, make the argument that health and health workers affect all other aspects of society. There was a report done by WHO about a year and a half ago that showed that the Ministry of Health budgets for health workforce, you average around 45%, but in low-income countries can be as high as 90%. So this really is often the majority or the largest line item in a Ministry of Health budget. And so how this money is used, the type of skill mix you have, really affects the budget and what's going to be done. For example, if you have a very physician or specialty heavy skill mix and workforce, it's going to be very expensive, harder to get them into the rural areas, whereas if you choose a skill mix that's more based on mid-level providers, community health workers, health worker extenders, not only are you going to have a lower wage bill, you'll be able to hire more health workers and really drive the care down into the communities where they're needed. And also we need to keep in mind that health workers decide how that other 55% of the budget is used. There's kind of a saying that 90% of medical costs flow from a physician's pen, that the decisions a health worker makes, should I prescribe antibiotics for someone I really think has a viral cold? Should I make a clinical diagnosis or do I need an MRI or an X-ray? This is the type of thing that can significantly drive healthcare costs and makes the health workforce and how they're trained and how they're supervised to keep in mind both quality and cost effectiveness is very important. Also, as we know, the world is aging. When we look at, for example, the U.S., where over 65% of U.S. healthcare dollars are spent on older people. As countries age, healthcare expenses are going to be driven up, and so we need to rely on our health workforce to help keep us cost effective. Also, as Ariel said, in many countries, the growth of the health sector has exceeded GDP, so it's very important that we engage health workers in cost containment and in high quality care. And we also know from an economic perspective that poor health and healthcare costs are the major causes of people falling into poverty. So this is a major economic issue. And so how we engage health workers in, whether it's not taking money under the counter or providing cost-effective care really is going to affect this issue. As several people have mentioned before, health professional schools, local hospitals and clinics are economic engines, and they really can put a great deal of money back into the community. And we see a lot of governments that actually have resourced healthcare spots, but they can't find the people to fill them. And so this money, rather than being spent in the community and being in the community, is instead maintained centrally and not spent at all. Also, from an environmental point of view, health workers can really contribute. As many people know, with growing population growth, there's a great deal of deforestation. There's also incredible unmet family planning need, unmet contraceptive need. And as we can get health workers down at the community level, health workers who understand the cultural issues around family planning, we can get this unmet need satisfied and help prevent some of the overpopulation that causes deforestation. And this isn't just important because of the climate issues, which are quite significant, but also the deforestation and the interaction of humans with that environment is where Ebola and where Lassa fever and where some of these new zoonoses and emerging diseases come from. It's when humans are pressured by overpopulation to interact with the environment that we get these problems. Also, one of the things we all know that was unique about this Ebola epidemic is it was urban. Urban overcrowding, is just a perfect storm for epidemics to grow out of control. Whereas in the past, these epidemics in Uganda and DRC have been in rural areas and are very easily contained. And from a gender perspective, as has been mentioned, healthcare workers, particularly nurses, are often the only visible women with higher degrees in their communities, and so they can serve as incredible role models for girls and young women to seek education, to become leaders. But we also need to help our women healthcare workers to become leaders as well, because often there is that gauze ceiling that prevents them from going into the leadership. Another issue, actually going back to the environmental issue, many of you are familiar with the problem of indoor air pollution, which is also an environmental issue, but it's also a health issue. And it's actually been the health sector that's really been the driver in helping communities and households move from biomass to clean liquid fuels. And so this is a real health environment interaction. And on the issue of social sustainability, I've already mentioned the gender issue, and there's a movement by a number of actors, including the International Council of Midwives, the IFC, and InterHealth, to look at the economic empowerment of women healthcare workers, what's often called midwifery enterprise or health worker enterprise. Right now, there are a lot of female health workers who aren't engaged in the labor market because the only option is full-time work, and that might not satisfy their current family or social needs. But if they were able to open their own clinic, to become a business owner, to pick and choose their times and hours of operation, they would stay in the labor market and we would get the value of their labor. They would also be empowered as entrepreneurs and have more power actually within their own households because they had their own income that they could make decisions with. We also believe that healthcare workers in the health system contribute to peace and sustainability. Healthcare workers are often in many communities the only outpost of government, maybe along with teachers and the education system. And so when the population thinks, well, what does my vote buy me, or what do my taxes buy me? The answer is quite often the healthcare workers. And we do know that often the inability to provide basic social services such as education and healthcare is often a cause of unrest, and that certain groups do try to provide these services as a way to destabilize government. So we do believe that healthcare workers are an important part of peace as well. And many of you might have been at the event last night looking at healthcare workers being targeted for violence. That's certainly an issue as well. So I really want us to talk more in a general dialogue about the role of health workers, across development, not just in the health sector, how they contribute to economics, contribute to gender equity, contribute to environmental and social stability. I look forward to your questions. Thanks.
Thank you very much. Thank you very much. Certainly, what I heard this morning is very music to my ear, because I'm really seeing a shift in the conversation to how do we really have a very practical approach to this? How do we change the conversation to really focus on the centrality of the health workforce in terms of economic development? And I think Kate really showed how broad a spectrum we have here if you start thinking multi-sectorality and if you think the intersection with environment and so forth. Let me open this to Joanne. Did you want to have a few words?
No, I think you've done a great job.
we just want to open it up to the crowd.
Hi, I'm Connor from the International Federation of Medical Students Association, and just wanted to compliment the panel. I thought that was incredibly refreshing and inspiring, considering the conversations we've had so far this week, from reframing it as an opportunity to talking about task sharing, redefining who and what is a healthcare worker, talking about big data, affirming the importance of the healthcare worker and the socio-economic opportunity. So taking all that for granted, I now want to ask, how do we actually translate that and communicate it to, in particular, the academic or the educational institutions who are in themselves very much a business? Thank you.
Who wants to take that one? Ariel?
Well, thank you. There are many conversations taking place, obviously, and all of the consultations going into the new global strategy, working groups on different ideas. There's been a working group just devoted to those who are involved in transforming the education and so on. I think the education part on the health sector on the pre-graduate and graduate levels is one that is changing in many ways. In many countries, the ministers of health control the health sciences schools. In others, they don't, and that sometimes creates gaps in. And perhaps more importantly, governments have traditionally see themselves as in health as the providers of education and health. And yet you see this explosion of private providers in the service, in health services, and also private universities. And so how the governments get their heads around this, how do you embrace this, is another opportunity, but also attention that we need to address. So all of this is being framed in the discussions, and there are many good examples. Some countries have done this very well, other countries have not done as well. But I would say that as we look at those issues, particularly the public and the private part, the point that Kate stressed on the skill mix is so important. If the skill mix is not fit for the economics and the stage of development in a country, you end up distorting the system away from efficiencies. And even though there's, intention, so I think having an awareness of what you're doing when you are involved in the production of health workers, and how they fit into the larger systems and the larger economics of the countries, is probably one of the most important things we can make across all of the angles of the system. But yeah, very important, and we are minding it.
And I'd like to answer
You wanna
that
add to
as
that?
well. In order to be able to organize, the schools and sort of pull them all together, you need to be able to communicate with them, and you need to be able to know where they are. And we have pretty much a lock on that with medical schools. The WHO and FAMR have a relatively good database, though I must say when about 6 years ago, Gates funded a survey of African medical schools, they found 60% more medical schools than they expected to find. So it is indeed an issue. As far as nursing schools, we have no idea. It's estimated for every one medical school, there are 40 nursing schools. We have no idea where they are, who they teach, how many they graduate, what the quality is, what the competencies are. One thing that IntraHealth has been engaged in a dialogue with LinkedIn, which, as you know, is the world's largest professional social network. We believe by using some of their data and by crowdsourcing other data that we might be able to find where these nursing schools are and communicate with them systematically, be able to create an open source curriculum for nursing so that, right now I can guarantee you probably 100 nursing schools are rewriting their curriculum at the same time. What a waste of resources. Why can't we have one global nursing curriculum that can be adapted to national level needs, maybe with different models for different resource settings? That would really change the whole economics of managing the health workforce. Also, we have an incredible opportunity in that the African Development Bank, which has all the African countries, as a member, has created an African virtual information highway. And there are two parts to this highway. One part is where the nations post their official data. And another part is where anyone can post data. People can crowdsource data. People can post data from their research. We really need to take advantage of this platform and get as much data about the health workforce and health facilities on that platform.
And David, you wanted to have some
Yes,
perspective?
I'll add to that as well. One thing to think about as an academic center or academic centers is you really have to be innovative in how you think about what your business model is going forward. A little bit to what Kate's talking about is that technology is going to drive education going forward, and it's going to drive democratization of knowledge, and it's not going to be housed at the academic centers any longer. It's truly going to be democratized. Let me give you one example of a project we're working on in the U.S., but I think there's going to be global implications as well. In a southwestern state in the United States, New Mexico, there are about 12,000 patients with hepatitis C. It's a very difficult and ultimately can be fatal disease. There's one liver specialist in the state of New Mexico. There's no way he can manage 12,000 patients. So what he did about 10 years ago was say, I need to democratize my knowledge. I'm the only person in the state who knows how to take care of this disease effectively, and created something called Project ECHO, where now what he does is what we traditionally know as medical rounds. He does it using technology, where he can see the community health workers, the nurse practitioners, the physician's assistants, and the primary care providers on a screen They present their cases to him, and actually to a team that includes a hepatologist, a gastroenterologist, a social worker, a pharmacologist, and they present their cases on a weekly basis. And what they do on a weekly basis, much like medical rounds, is they review the case, they make recommendations on the case, and they teach the community health workers and primary care providers how to manage hepatitis C. And so now, by democratizing that knowledge, you now have people who are not liver specialists able to manage a very complex liver disease. And this was published in the New England Journal in 2011 or 12, showing that those community health workers or providers could take care of hepatitis C as well as the specialist up to a certain degree. The promotion of healthcare in the primary care setting was improved. The self-esteem of the physicians, the retention of the physicians and nurses was much greater. And this was simply by saying, I own the knowledge, I've got to disperse the knowledge. And that now there's about 40 different hubs around the world that are not only dealing with hepatitis C, but other diseases like rheumatology, cardiovascular disease, cancer. And I think that model of changing what the academic centers think of holding on to that knowledge, changing that model, I think will have a tremendous impact in how you think about what you're doing and your business models going forward.
John?
Yes, I'd just like to connect a little bit of the financial argument in this discussion in terms of the new paradigm, the question you posed earlier. On Tuesday, at the discussion we had a lot of CEOs of the new investment firms. The Center for Global Health and Diplomacy has been working with a lot of new CEOs of investment firms or new companies. And a lot of what you're seeing is these investment firms that are billion-dollar investment firms wanting to invest in health workers. They know that in order to connect the bottom of the pyramid with the middle of the pyramid, they need the healthcare workers. So it's really become a new shift in how we see both economically sustaining the system within itself, but it's almost they're doing it for a return on investment. So I think that's something we should consider too at some point. It's just a new shift in paradigm that we should take into account.
Do we have one more? Oh, we have, let's see, one, two, yep, two questions. Yeah, you can start with the gentleman here.
Great.
And microphone.
I want to pick up on Joanne's point on return on investment. So, Kate, you talked, I think, very eloquently on the economic and the environmental and the social sustainability aspect of this. And I think most people at this conference would say we're preaching to the choir on this, and the reasoning is very sound, it's very rational, yet somehow there's a massive disconnect between the investment and this argument. And I wonder, and I pose it to the panel, on this ROI question, is this a poor argument on kind of cost-benefit analysis here? Is there a flaw in the reasoning here, or is there something that we're missing, maybe in terms of the way that we articulate this argument? And David and I had this conversation. Is maybe this that the public wants an outcome to change. They don't care about this financial analysis. They want an outcome to change, and we have to articulate how healthcare workforces are going to change that outcome. I'm interested in your perspectives on this cost-benefit analysis and this outcomes perspective and how healthcare workers play in that.
Okay, let's take the second question at the same time, because then we need to answer and wrap up. So.
Thank you. It's so interesting. My question is so similar to Christian's. I know, because yesterday I was on a panel where we had the Minister of Health from Botswana, and she said she used to be in finance, and she now got to the position of Minister of Health. And she said health, and I agreed totally with her, health needs to be run like a business, and what we're having is that we don't have the political will. And if you look at across a lot of governments, health is not a priority. You talk to ministers of finance and they say, yes, it's not just about saving lives. We don't have an open-ended budget, so we need monitoring, we need evaluation, we need a return on investment. And so my question was, how can we come together, to really have monitoring, evaluation, and actually some timelines and timescales and impact assessment? So for example, Ariel in USAID are doing so many projects, which is great, but how then, and in different countries, you have USAID, we have DFID, we have Bill Gates Foundation, we have UNFPA, we have UNICEF. How do you come together and then pool those resources together and then make it more sustainable for the government? Because what they are doing is they are drawing from different parts, and because we're not working together, sometimes it doesn't become sustainable. It does work in some cases, but if we're still having 800 women dying each day, it means we haven't achieved it.
Thank you.
Thank you.
Thank you. Okay, so I think those will be the final question. What I'd like to do is ask the panelists to respond to those questions and then give us any final thoughts you might have on this subject, including, if I may ask a little bit, because we haven't heard a lot. I think Ariel did mention frontline health workers as a key element. We are still working in an environment where if you only stay with the professional cadres, you will be leaving a lot. So I would like your thoughts on community health workers who, as we all know, are not even officially part of the healthcare systems. Let's do that. So this is your opportunity to answer the question and give us your final thoughts.
Well, thank you. But simply starting to say to you that there's no doubt that community health workers, as Kate noted, and I pointed out with the skill mix, is fundamental to addressing development. And now in West Africa, this new pyramid of HR will be largely based on community health workers. And just the question on the cost effectiveness, cost of investments versus the demand of people. And I see those as two sides of the very same coin. The Lancet Commission has been made very clear why investing in health is very important. There's very many economists to show why the return on investment for society is such, and you can monetize that. You can monetize the value of your health, the value of your life. And you have to be cold-blooded to do that, but economists do that. And but at the same time, there's more individual sense of the demand. People just want to have access and get services and do well. And it is precisely because of that, because people value health. And one of the interesting things in the economics of health is precisely the fact that there is an insatiable demand for health, for well-being, for certainty, for immortality. And to the extent that is the case, economics don't work as well as in other sectors. In agriculture, efficiency eventually meets demand for food. Food eventually gets cheaper and shrinks as part of the economy. That's just what you can expect. Not in health. Even in other desirable things. Education, well, you can always learn. But paying for degrees, maybe at some point societies will begin to figure out technological solutions, as we heard before. But in health, again, this insatiable appetite for well-being and certainty means that people, as the economies grow, will be investing more and more in health. And so the two things are quite linked, and yet because of that different nature of health and the uncertainties involved, as we heard before, that some can be addressed but some cannot, is that you see a lot of variation, but also running it purely as a business is more complicated. So commodities, the commodities part of the health sector and some of the management part of the health sector, the private sector, the business can do a lot of great work easily there, and foreign direct investment is thicker in that space. When it comes to the individual private provision, it's more complex how to organize markets there, and we've been trying for decades because we want the efficiencies of that, but I think it will be slightly different. To the question of coming together with so many players, and I believe in the open source anarchy theory of global health architecture, that is by virtue of inviting so many players to the tent of global health, that global health has been so successful, even if there's an obvious transaction cost involved. But there's also clearly an organizing opportunity for efficiencies, and the Global Financing Facility is going to help us do that. Every Woman, Every Child, Secretary General has allowed us an umbrella for policy alignment, and the Global Financing Facility is giving us a platform for financing alignment and with the government for sustainability. Thank you.
Thank you. So I'll address the private issues first. I think we're at the tipping point with the private sector. We now know that there are major private equity firms that are moving into pre-service education of healthcare workers. They make the back offices more efficient. They can actually make either break even or make money on pre-service education. We also see that currently the largest educator of dietitians in the world, which will be very important in the NCD era, is a nonprofit school system. It's the largest nonprofit school system in the world, and they're rapidly becoming the world's largest trainer of nurses. So this is indeed the private sector. In the public sector, I think we need to both get the incentives right, and also the ministries of health need to learn how to talk to ministries of finance. Actually, USAID has funded the Health, Finance, and Governance Project to put together a toolkit on how ministries of health can talk to ministries of finance. You know, many of us in this room and in ministries of health believe in health as a right. Ministries of finance don't. And they look at health and they see it as very inefficient, full of corruption, not producing anything. If I give you $1 million extra, what can you produce to it? We wave our hands and don't give real answers. And so we need to be able to speak in their language, you know, determine the cost effectiveness of our investment so that we can tell them what $1 million will buy. And also, I think many ministries of health are going to have to be the good faith first mover. They'll say, okay, we will get rid of our inactive workers or ghost workers. It's estimated that on most payrolls, 20 to 30% of the workers are ghost workers. We helped the Dominican Republic to remove over 10,000 health workers from the payrolls, save $6 million a year so they could hire more real health workers and pay them more. Also, another good faith effort that ministries of health can make is to tackle the issue of absenteeism. Bangladesh really has led the way on this with biomarkers where health workers have to swipe in and swipe out, and they've been very effective at reducing absenteeism. Because until the Ministry of Health makes these efforts and shows that they're serious about cost effectiveness, why would the Ministry of Finance give them more money? And also, I think we need to become very smart in how we drive the incentives. Uganda has a huge problem with quacks. And so we were working with Ugandan Medical Council, and they use our IRIS software, which is free open source software to manage health workers. We set up a system so people could text in the name of a physician and find out whether or not he or she was registered, whether or not he or she was a quack. And this was a win-win-win situation. Patients won because they could find out who they really needed to go to. Real physicians won because they didn't have to compete with the quacks anymore. But perhaps in a way the biggest winner was the Medical Council because their registrations went from 200 to over 2,500. So they now have more timely, accurate data on physicians to plan with the Ministry of Health. And also they have increased revenue to do their good work, and they actually bought a new building. So it's really this incredible example of win-win-win that technology can bring. And that's actually a real good way to segue into David's comment about the biomedical technicians. I would also add health information technologies. You know, the cell phone is a new stethoscope, but we have to have the health workers who can keep these systems running. Thanks.
Thank you, David.
It's always great to be the last person. I guess Joanne is going to be the very last person. So I have a couple of comments. Some are disjointed, but hopefully they'll tie together somehow. In terms of what Gisela and Kristen were talking about, you know, I think you have to approach this as a little bit the two sides of the coin that Ariel was talking about, but I would look at it as two sides of a vice squeezing together. I think you get the economic argument, which is sometimes a little bit fuzzy, but there's data there. And then you get a bottom-up approach from patients who are going to start to demand care because it improves their well-being and their sense of what they want out of their lives. And as you start to push hard from both ends, you'll start to see that you'll get some traction and start to develop the healthcare systems you need. In terms of what Gisela said about the health ministers and the finance ministers, I have to say there's a program that we're funding at Harvard, which is the Harvard Ministerial Leadership in Health Program, where they don't just, they're doing some leadership training for ministers, but not just the ministers of health. They train at the same time the ministers of finance in health. So, and they do it from the same countries. So, for example, you'd have the Minister of Health from Botswana and the Minister of Finance from Botswana in programs 2 months apart so that they can partner on advancing health within their own countries. And they've been doing that for a number of years with great success. My last two comments are the one where I think, actually I wrote a note here, hold on one second. Yeah. Oh, I know, the open source anarchy. It gives me a lot of agita to hear that open source anarchy actually is the way we should go forward. I would think about it a little bit differently, that there is anarchy and there is open source anarchy, but the way we need to think about getting stuff done is look within that fog and pick out the simple interventions that you think are going to make a difference, find the right partnerships to deploy those simple interventions, and be leaders in getting those things done. And I think that's the way we look at that fog or that anarchy and really make progress going forward. The last thing related to community health workers is I think we need to professionalize community health workers. There's no way that we're going to grow the community health worker force in a substantial way in Liberia or wherever else unless we professionalize community health workers. That's been demonstrated in Liberia. Last Mile Health is professionalizing community health workers and has grown them tremendously. And I think there's lots of other opportunities for us to take similar models and make them professional health workers as opposed to voluntary community health workers. So.
Well, thank you so much. I don't know about you, but I could stay here and listen to these guys forever. But yeah, I want to give Joanne the last word. But I just want to conclude by saying, I think I asked for a paradigm shift, both in the conversation and we need to be there. I think we had plenty of examples. So I personally wanted to thank the panelists for their insight on this subject. I mean, it is clear that this subject is here to stay, but it is also clear that there are a lot of solutions. And on my part, I think the private sector coming into this space and the new social entrepreneurs coming into this space, what we have now is new energy, new thinking, and really a skill set that is lacking in the traditional NGO community, or new types of focus that I think our field is going to need. Finally, I just wanted to thank Joanne and Global Health and Diplomacy for putting together this event. I think this has been a tremendous one, and we are grateful to have been given a chance. Thank you.
No, thank you. Thank you to you, and thank you to all the partners, governments, and private sector in the room. We really appreciate, your support, and these cross-sectoral partnerships and mobilization can't happen without you in the room and also the online viewers in the room. Thanks again. We do welcome your comments. We're going to be writing a report from these different sessions that we will then circulate to our network of 42 governments. So we really encourage you both on the online viewership and within the room to please forward us comments about your thoughts so we can put it in our report. Thanks again.
Thank you.